ready to begin.
Fantastic. Welcome, everyone, to the webinar today. Really looking forward to implementation of UDSv4. We did get a lot of feedback on the clinical task force and the clinical core steering committee about some help for those of us that are not DSM-5 savvy or psychiatrists in terms of the points and topics where this becomes important for us for a large number of reasons that we'll get into today. I'd really like to thank a colleague of ours who needs no introduction, and that makes my introduction of him much, much easier. Kostas Lyketsos from Johns Hopkins University to really share his expertise with us today. But I do want to thank the entire clinical core steering committee that has worked together in a team effort to pull together cases and to assist with this. Amy Pierce from Oregon, Liana Apostolova from Indiana, Doug Glasgow from UCSD, and the NIA, as always, and especially I'd like to thank NACC for all of these training opportunities for a seamless launch into UDS 4.0. So we're not going to take questions during the presentation itself, but please, as questions come up, put them in the Q&A. And we will have ample time for Q&A and to address those sessions, and I'll come back and moderate that Q&A session. We do have other members of the Clinical Core Steering Committee here, as well as resources for us all. So with that, Kostas, please help us understand the complexities of DSM-5 in the UDS-4.
Thank you, Greg, and thanks everybody for participating and for everybody who's part of the steering committee, the task force, and NACC for really helping put this together. These slides and a recording of this presentation will be available. We decided to keep it at 1 hour for interest, so some things we might go over a little bit faster than you'd be comfortable with. You will have the slides and the recording to come back to. So really the objective of the webinar today is first to discuss the context of using DSM-5 criteria in UDS-4. I'll just make the point and not come back to it. It's now DSM-5 TR, reflecting text revision. We'll talk about very quickly about how you can easily access and look at the actual criteria using your institutional psychiatry online subscription. We'll then have 2 cases with 3 scenario each, so 6 scenario to go over, where we'll see if we can help you with your thinking and also how you rate the forms. And there are 2 prior webinars that you can go to. These are all here when you get the slides. These are all hyperlinked. You can go have a look at these prior webinars that are relevant to this material. So why is this important? Well, neuropsychiatric symptoms across the various stages of a cognitive disorder obviously have been very important for a long time, but it's in the last 5 or 6 years that there's this big interest in their occurrence before the onset of dementia, whether it be in folks with MCI or cognitively unimpaired people. So these modifications are trying to strengthen our ability to capture information and make relevant diagnoses, primarily in the pre-dementia phase. So we also want to incorporate a diagnosis of NBI, and that was the subject of a prior webinar. An important goal here is to standardize diagnosis of psychiatric disorders. Every center will often make a diagnosis, but it's not been clear to me that everybody is using the same standard. And DSM, as cumbersome as it can seem, is also straightforward enough that I think can be used for this purpose. So that is what we are proposing as the common standard. Now, we are not using a typical way of ascertaining the presence or absence of DSM criteria. And I'll repeat that a few times today. There are these complicated interview schedules that take time I think we're going to have to focus on clinical judgment by knowledgeable clinicians. And that's really part of why this webinar is being put together. So what is the DSM-5 diagnostic approach? It distinguishes, as we always do in medicine, between symptoms, sadness, anxiety, euphoria, which are typically nonspecific. They occur frequently. They are often reactive, the term used loosely, to what's going on day by day, moment by moment. And typically symptoms are transient. But when symptoms come together, in this case, we use major depressive episode, into a syndromic state where we have specific symptoms present. Many times we have signs. There's specified severity, there's minimal duration. So for example, for major depressive episode, you need to show a sustained change in mood. It's not enough to have mood that goes up and down in relationship to environmental events. So it needs a specified severity and a functional impact, whether it be on social, interpersonal, or occupational functioning. This does not call for impact necessarily on ADLs, for example, which is one way to distinguish the effects of the cognitive disorders. So you will see the term major depressive episode or panic episode. These are syndromic states that will appear in DSM, but their cause is really where the diagnosis of disorder comes together. So in general, if a syndrome like major depressive episode is occurring in someone who has brain disease or other disease that is known to cause this problem, or as a result of medication or substance use, etiologic attribution goes to that condition. It is a depressive episode due to, if you will, neurodegenerative disease. The term major depressive disorder is, if you will, the idiopathic attribution, where you've pretty much ruled out other etiologies and conclude that this is an idiopathic condition that we call major depressive disorder. So how do you get to these criteria? So when you get the slides, I'll show you how you do this. This is the link to Psychiatry Online. So you click on the link. It takes you to this page. You go down to section 2, where you have diagnostic criteria and codes. In this case, we're interested in depressive disorders. So you click on depressive disorders, and then you do a page search for F32. In this case, you have to know that ahead of time, and voila, here are the criteria for major depressive disorder. So it's a really straightforward process to be able to go there and find these criteria. This page here offers you the numbers for the conditions that are specified in the forms. So if you have a question as to whether someone has panic disorder, which is a rating you could make on one of the UDS forms, then you can follow the process I just showed you. In this case, you'll go to the DSM at Psychiatry Online, you'll go to the page that relates to anxiety disorders, and you will do a search with the term F41.0, and you will see the criteria. So you are pretty able quickly to get to these. For copyright reasons, we can't provide these to you, but because you have institutional subscriptions, you should be able to get a hold of these pretty easily. And that way you'll have a reference if you're thinking about making a particular diagnosis. So what are we proposing to do in UDS4? Well, we are capturing psychiatric symptoms on the NPIQ, which is really caregiver report, GDS, and B9. B9 is much more broad than the GDS. Individual sites, individual centers might add scales. That's up to you. But really, the first step is to capture the presence of the symptoms. Then you might be asked to rate these on B9. If there's a past psychiatric history, you would rate it on A5D2 in section 6. And if you are, as we'll spend most of our time today, it's really the new D1A where the issue becomes that you might have to differentiate conditions like MDI from a DSM disorder and make a judgment call about a DSM-5 condition to the clinical picture. So what's the flow of clinical reasoning that we're encouraging you to follow? Are psychiatric symptoms currently present? Again, GDS, NPIQ, B9, local measures, your own clinical judgment will lead you to decide whether they are. The next step is, are they clinically impactful? If the answer is no, you're done. You've captured these symptoms already in these stages, but you don't have clinical impact. You don't have a disorder. What is the presumed cause? And this is perhaps where you'll have most of the challenges in making a distinction. So as you will see, for all so-called DSM idiopathic disorders, there is an exclusion. You can't make the diagnosis if the disorder is attributable to the physiologic effects of a substance or another general medical condition. So you can't call major depressive disorder if someone has had a stroke, which is causing the major depressive episode or which is causing the atypical depressive episode. So this is really the basis for that. You'll have to apply clinical judgment as to do you believe there is a condition, and frequently it'll be whatever's causing the dementia or the MCI. Do you think that condition is the cause for the psychiatric condition or not? We also assess, well, let me just keep going on this. I'm reminding you again, we're not using a standardized DSM diagnostic tool. So we're basically using clinical judgment as to whether DSM criteria are met currently or not. And if it is, then you assess its effect on a cognitive disorder. I'll illustrate that in a moment. And A5D2 would be met in the past and might still be active. You'll see again in a moment how this shows up in the form. A general note, the DSM is flexible. There's a DSM category for everything. There's a DSM category for a mood disorder due to a stroke, but we're really not asking you to apply that in this case. It would be way too complicated. We're mostly interested in the 8 or 9 common psychiatric disorders that occur in the patient population we're talking about as to whether they are present as disorders and impacting on patients clinically in some way. So if you're dealing with someone who's cognitively unimpaired or has MCI, in the D1A form, the first judgment you have to make is whether or not they meet criteria for MBI. So the key wording here is, although comorbid conditions may be present, the behavioral personality changes are not attributable to another current psychiatric disorder. And you see a few listed there. So often the judgment call that you'll have to make is if someone has psychiatric symptoms that kind of looks like major depression, when is it major depression or when is this MBI? And we'll talk a little bit about that. It depends on a couple of things that you'll see. And again, the exclusionary part for meeting criteria for DSM disorder. So how do you decide whether someone has MBI or not, or whether they have another condition like a mood disorder? So one way to look at it is, what is the age of onset? If the age of onset is in late life or around the current condition, the current cognitive condition, if there is one, that favors an MBI diagnosis. If the onset is earlier in life, especially many years ago, that favors a other psychiatric disorder that is now in a relapse or persistent situation. Another way of deciding is, what is the NPS symptom profile? If it's atypical, so major depressive episode, again, or generalized anxiety disorder, very specific symptoms that are associated. And as you'll see in a moment, there are differences between anxiety symptoms and anxiety symptoms. So the symptom profile will help lean you more in the direction of MBI or generalized anxiety disorder, for example. You will also see whether the patient's current psychiatric symptom profile is similar to what it was before. If they've had generalized anxiety, as you'll hear, for much of their life, and it's remitting and relapsing, and now they have MCI and they're 82, and they have a symptom profile of anxiety that looks very much like their GAD, then you might conclude that the symptoms are better explained by GAD. But if the symptoms are very different, and you'll see in one of our cases how that might be, then you could conclude that this person has MBI with the anxiety features being the prominent presentation and the prior history of GAD that appears to be in remission. So this is the kind of reasoning, trying to think of attributionally, what is the best way of explaining the presence of the symptoms? So does the participant meet criteria for MBI? This is a new set of slides. If the diagnosis that you've made is dementia, you cannot diagnose MBI. That's just by definition of the MBI. Does the participant meet criteria for a DSM disorder? Well, now you've got dementia and you've got a presumptive brain disease. So how do you make the judgment as to whether this presumptive brain disease, which often will be Alzheimer's, but might be Lewy body disease, we all know what the other conditions will be. So at what point do we say in dementia that this patient's neuropsychiatric condition is the result of the brain disease that's caused the dementia, or a persistent or recurrent previously existing psychiatric disorder like a major depressive disorder? So again, it's the kind of reasoning you'll have to make. Is this new late life onset? Did it start after the dementia started? Did it start 5 years ago before there was any sign of cognitive symptoms? What does the symptom profile look like in relationship to past symptoms and so forth? Is the kind of reasoning that you will apply when the diagnosis is dementia. So let's move on to case studies. Greg is going to help me with his. Amy was going to help as well with hers, which is case 2, but she's asked Greg to do this because her voice is not cooperating with her today. So Greg, let me just make the point that we will be coming back to this table periodically, making the point that we're going to be seeing people in this sort of period of interest and observation. We want to distinguish whether they are unimpaired in a cognitive prodrome or have dementia, or a prior state before any of either the observation started or the cognitive prodrome. So we'll be looking at what the data tell us about presence or absence of symptoms in different time frames. So Greg, case 1.
Fantastic, Kostas. You know, this is getting clearer in my mind every minute that I sit in on this webinar. So I'm delighted. So these are our cases that are really modeled after what we see in our consensuses. So I'm not going to read the whole thing through. You have it on the slide, but we'll touch in on an important point. We've got an 82-year-old woman with no significant past psychiatric history. So we think that that's already potentially a clue. She does have cognitive and functional complaints from both herself and her informant, leading to a functional assessment scale score greater than 0. That's form B7. She tests in the cognitively impaired range, showing some abnormalities in 1 or 2 tests. And she's been experiencing a depressed mood for the last 8 months. That's concomitant with her cognitive and functional complaints. Overall, the level of her symptoms could meet criteria for a major depressive episode. Next slide, Kostas. And of course, you know, as all good ADRCs, we do a workup. Her evaluation, unremarkable for medical causes for her depression, unremarkable for reversible causes of dementia. Her MRI looks normal. Her plasma and A-beta PET biomarkers all showing no signs of a degenerative disease. So now we're left with, what do we do with her depressive symptoms?
So we have someone with neuropsychiatric symptoms, in this case depressive, that are occurring during our period of observation. This person has what appears to be a cognitive prodrome, but we don't have evidence on imaging of a specific neurodegenerative or vascular disease. Basically, MCI that we still don't know whether there's AD pathology, but we're not seeing it. But we also note that this person's condition meets the episode criteria. So it has the symptom profile and severity of a major depressive episode. She has no prior history, but we don't have an alternative explanation. So in her case, we would rate her as having major depressive disorder with late life onset. And we would rate, this is the first section of relevance in form D1A. So does she meet criteria for MBI? She does not, because the condition can be explained by a psychiatric disorder by DSM criteria, which is the yellow highlight that you see there. So she does not meet, because we have concluded that this better fits major depressive disorder with a late life onset. So we would record this again in form D1A in section 3, item 10, as you see here, major depressive disorder present, And then you will make a call as to whether this is contributing or not. I've checked the contributing box here, but it's really the clinical judgment that you have to make. Do you think the cognitive disorder is a result of the major depressive episode? And in terms of the psychiatric history, this is Form A5D2. You will rate the major depressive disorder as recent and active, and all the other conditions here, there's no past psychiatric history, are absent, no bipolar all the way down here. And if you ever want to check on the criteria, I showed you how you can do that. Same case with some modification, Greg.
Fantastic. So again, we're working on the case here. You know, the general background the same, some cognitive and functional complaints. We're picking that up on our form, some mild impairment on her testing. At times she's sad, often irritable, paces a lot in the evening, worries about minor things, and is suspicious of family. The rest of the assessment clinically is unremarkable, but then we move on and evaluate her. We find no real medical explanation for her depression. We look at the MRI scan, and we do see left greater than right medial temporal lobe atrophy. Her p-tau 217 is elevated, and her A-beta PET is positive. So now we have a very similar case, but now we have positive degenerative biomarkers. Kostas?
So again, we have neuropsychiatric symptoms, no prior history, the person's in the cognitive prodrome, there is evidence of neurodegenerative disease, and the symptom profile doesn't fit the symptom profile of a major depressive episode. And even if it did, we would struggle in the presence of neurodegenerative disease to say, is this major depressive disorder, or is this neurodegenerative disease causing a major depressive episode? So here, the better approach, I think, is this is mild behavioral impairment. The symptom profile is pretty typical. It's atypical for a primary affective disorder, primary mood disorder. There's no prior history, and there is evidence of neurodegenerative disease. So you would record D1A. The MBI question is yes, criteria are met. You would record the affective regulation symptomatology. You would say no to all the other ones, motivation, impulse control. I didn't do that here, but you would say yes to affective. If she also had delusions, you would say yes to the delusions as part of that here. And then the primary or contributing non-neurodegenerative or non-CDD conditions is blank, because there isn't one in the past and there isn't one now. So you don't need to record anything on this form. And the same thing, you would record the prior absence of typical DSM conditions, as you see here on A5D2. Well, finally, the third iteration of this patient, Greg.
So again, the same patient, no past psychiatric history. Again, some cognitive complaints and functional complaints leading to elevations in the FAS score on Form B7, some cognitive impairment recorded on Form C2. At times, she gets very irritable when she forgets. She worries about minor things, but is able to be reassured and distracted. Other aspects of her clinical assessment were unremarkable.
So here, it doesn't really matter whether or not she has neurodegenerative disease, because the neuropsychiatric symptoms are not impactful. So we have recorded them, but there's no clear MBI or MDD. There's no clear change. These are not persistent symptoms. They're really not affecting her function. So they are captured symptoms. We know they're there, but we don't really need to go beyond that to make a diagnosis. So we would record basically no to MBI, and we would leave blank all the other forms. Switching to the next case, case study 2 from Amy, read by Greg.
Fantastic. So a 68-year-old woman looks like one of our average participants who comes in beginning to experience some forgetfulness, word-finding difficulty, multitasking over the last 2 years with a minimal impact on her daily functions. Otherwise, not any major surprises. We do know that she has a family history of Alzheimer's disease and is an ApoE4 heterozygote. Her CDR comes out at a 0.5. She's testing in the mildly impaired range on form C2, and we didn't have any other biomarkers available. So she has a long-standing history of anxiety symptoms, going back to age 16. She's been treated in the past for this on multiple different medications. She doesn't have any other psychiatric or behavioral symptoms. She does seem to have some active problems with anxiety over the last 6 months. Her anxiety is present on the majority of days and are quite severe. So she's finding it difficult to manage some of her anxiety, some of her worries as well. And she does have many associated symptoms: restlessness, feeling keyed up, fatigued, irritable at times, muscle tension, unsatisfying sleep. And these symptoms are causing her significant distress, beginning to influence her occupational functioning as a result of not only the memory, but also the anxiety.
So this is a person who we could consider it has a lifelong anxiety disorder who now has neuropsychiatric symptoms during the period of observation. A variation would be the anxiety disorder was of more recent onset while the person was unimpaired. But in this case, the symptoms are better explained by generalized anxiety disorder. If you go in and you look at the GAD criteria, she fits them pretty well. So she has a lifelong condition, seems to be persistent, maybe it's less severe in the last several years, seems to have worsened, but basically the best explanation here is that she has GAD. And so again, you cannot diagnose MBI because of this clear-cut generalized anxiety disorder. You don't have, well, the generalized anxiety disorder is present and you might believe that it's contributing. It sounds like the anxiety is affecting her functioning to some extent. So you would leave all of these blank, but rate generalized anxiety disorder as contributing. And you would rate it again as recent or active on section 6, although the other conditions would be recorded as absent. So lifelong anxiety disorder, current anxiety disorder looks the same, feels the same, isn't MBI, is best explained as GAD. Scenario B.
Very good. So we're going back and we're looking at a different scenario, same patient really. Again, anxiety dating back to age 16 with treatment. In the past 6 months, her anxiety symptoms are persistent, but usually quite mild. Again, she has a lot of worry, especially about developing AD in the future. And you know, these are kind of pervasive thoughts. She can't really control them. The associated symptoms now appear to be different from her personal past, where worry and irritability are most prominent. She tires easily, has some somatic anxiety, different feelings and sensations in her body of restlessness, muscle tension, chest pain. Home functions impaired with some weekly outbursts of these conditions. She's hard to calm.
So this is a patient who has GAD, but seems to have something different now because the topics around which she worries are different. She doesn't have the kind of physical symptoms that she had before, the so-called somatic anxiety that I've referenced here. It is impacting her, but what's impacting her more than anything are the weekly outbursts, that she gets very worried, and so it's a periodic rather than a sustained impact on her functioning. So it feels different, and this is where the judgment call comes in play. She has a prior anxiety disorder. She has neuropsychiatric symptoms. I would argue that this presentation is better explained by MDI. It doesn't really fit as well as the GAD as the first example of this patient indicates. So you would record MBI as yes, you would say the affective regulation is present, and you would rate no the other MBI domains if in fact it's a no. One or more might actually be a yes. And there is no GAD that's currently affecting things. So this section 3 of D1A is left blank. And you are now recording the presence of GAD in the past. You could call it remote inactive. I think this is where the judgment calls are coming into play, because obviously she has anxiety symptoms right now, but the other symptoms and conditions are recorded as absent. Third scenario for this case.
Very good. So again, the same case, but now we're switching it up a little bit. There is no past history of anxiety symptoms. So the anxiety really is an onset 2 years ago, close to her cognitive symptoms. And in the past 6 months, the symptoms are persistent, present several days per week, including worrying, being fearful, irritable, and agitated. And the anxiety is impairing her social relations on a daily basis.
So again, a different field, nothing in the past, but a syndrome that's occurring now in the context of the cognitive disorder. So this is again an MBI patient, nothing in the past. And so yes, again, so this is basically like the prior case, but I would argue we're more comfortable with this diagnosis here because of the absence of the GAD. Section 3 of D1A is also left blank. And you're basically recording absence of psychiatric DSM conditions in this situation. And I believe that was our last case. I think we got through them a little faster than we had planned. Thank you, Greg. It's been wonderful. I'm going to take down my slides, and why don't we see if we can take some questions. So, Greg, you're the moderator.
Fantastic. So it looks like we have a few questions that have come up in the chat for us today, but really, I hope that this is becoming clearer. I hope that everybody understands that there is going to be a need for good clinical judgment. And I think, hopefully that using these kinds of rules and guidances, we're really going to be able to standardize this across the field. So I will offer to folks, we had Diana Furman chime in the chat. Diana, did you want to unmute and ask your question, or would you prefer that we just move on with it, and I read the question and we review it?
Oh, either one is fine with me.
Oh, very good. You're on off mute now. Why don't you go ahead and voice your question for us?
So I was just referring to the first part when you say there are no medical causes of depression. So to find out that there's no medical causes of depression, there's a huge workup that needs to be done. And I wanted to figure out how this is done. You're looking for major illnesses like cancer, depression, chronic pain, head injuries, thyroid disease, medication side effects, and the list goes on and on. So I wanted to know how that's addressed and briefly done in one sentence.
Fair enough. So this is someone who's in a clinical cohort of an ADRC. So there's an extensive history known about this patient, about whether they have cancer, heart disease, chronic pain. This is known information, and it's being collected anyway as part of the ADRC. So the call that you have to make is whether any of those conditions that are such that they could explain a depressive disturbance, an anxiety disturbance, and so on, et cetera. It's actually quite unusual, at least in my experience with our cohort, that you will have someone where, for example, they have chronic pain, and the question is the chronic pain causing whatever depressive disturbance that you have? Clinical judgment is the way that you go about it. What is the temporal relationship between the pain and the mood disorder? What is the proportionality of the pain and the depressive symptoms and so forth? So we're not encouraging you to go on a wild goose chase to find. You go based on what you already know. You go based on the medical history that you have for your well-characterized ADRC participant, and you make a judgment. You say there are other factors: stress, abuse, homelessness. again, stuff that you will know because you're evaluating this patient very carefully. You'll have a lot of that information. Family history of depression or suicide. I'm not sure what you mean by chemical imbalances in the brain or genetic factors. But yeah, that's helpful information if you wonder whether someone has a major depressive disorder, for example, and it's a lifelong condition and there's a strong family history, that would lean you more in that direction. So I hope that answers your question.
Yeah, it's a complex question. I think in a nutshell, Diana, you use the information that you have. Now, if you're so concerned about the patient, you're going to send them for a clinical evaluation that's going to be done expeditiously. Maybe you want to hold off on your consensus diagnosis until you have additional information. But in the vast majority of cases, we really have the information. And you can't default to an unknown, right? If you don't have an identifiable other cause, it reverts to MBI or a DSM-5 diagnosis if the symptoms are impactful. Is that correct, Kostas?
I think that's the way I would see it. Yes, that's a good way to think about it.
Fantastic. And we have Paul Newhouse. Paul, did you want to unmute and
Sure.
discuss?
Yeah, so going all the way back to the beginning, Kostas, with that first case, if we diagnose her as MDD without neurodegenerative diagnosis, wouldn't we want to list the MDD as primary rather than contributing?
Yeah, Paul, we might. I wasn't clear. The point I made there is that it would be your judgment as to whether it's primary or contributing or unrelated. But yes, the way the case was framed, it might make most sense to say the MDD is causing the cognitive disturbance.
Yeah, fine, great, thanks.
Fantastic, fantastic. And we have another two questions from Sophia Wang. Sophia, did you want to unmute and ask those verbally?
Sure. Thanks again for this great talk. So when you say clinical judgment, are you indicating that we need somebody who at least has some sort of background in mental health training of some sort, faculty or, somebody with, some sort of healthcare license as opposed to staff? And the second one is I noticed you use biomarker data during the consensus diagnosis because that was available in the first one. Is that going to be part of the expectation in UDS 4.0 that we should be actively using the biomarker data as we check off clinical etiology? Because that, I don't know, that would be a change, I think, from how some people may be operating now. I just want to make sure I didn't misinterpret anything. Thank you.
Yeah, so great questions. I'll come to the second one in a moment. That's a huge Pandora's box that is not just about the psychiatric presentation. But on the first question, I think certainly in our consensus always involves a physician and typically a neuropsychologist. So there, at the time of the diagnostic consensus, we have the clinicians there. Many of our visits involve an experienced psychiatric nurse, but not all. So we have visits where people without clinical credentials are gathering the information and presenting it to the clinically qualified individuals. I'm not sure you need to change that. At our site, I've not seen that as a problem. Over time, the frontline research staff that are doing the ratings and collecting the data get pretty good about alerting you. So once in a while, I have to go back and talk to a participant and clarify a few things before we can complete the diagnosis. But I don't think you need a full clinical assessment every time with every participant if you've got good frontline, well-trained team. On the second question, this is going to be a challenge for all ADCs moving forward because we are now going to have the biomarkers available of various forms, and that'll be relevant to what cognitive diagnosis we are making. I don't think we have a clear answer for that. One possibility would be to say if you expect biomarkers, you should not do the consensus until after you have the results of the biomarkers. But we don't know how quickly the results will be coming, and so that could create problems on its own. On the other hand, if biomarkers come in 6 months and you did a consensus panel on a certain day and the biomarkers really are such that the diagnosis should be very different, you got a different kind of problem. So I don't think that's an issue that's specific to the psychiatric condition. It's a broader issue that we'll have with both psychiatric and cognitive diagnosis. Greg, do you want to comment on that?
Yeah, I'll comment on both questions. The first is there is no mandate that a non-psychiatrist go back and take a 4-year psychiatry residency before they can fill out a UDS packet. We're asking people to become familiar, which is the point of the webinar today, to be familiar with how we use the criteria to ultimately create clinical judgment. So again, our clinicians that are seeing our patients at annual visits, I don't happen to be fortunate enough to have a psychiatrist currently in my clinical core. I do have access to a neuropsychologist and then neurologists, nurse practitioners as part of the consensus process. And so we're really asking centers to work with the teams that they have, but to become familiar with a standardized application of this. In terms of question number 2, if you have biomarkers and information on the patient that could influence, and we saw in the first case how a person with negative biomarkers comes up with a different diagnosis than somebody with positive degenerative biomarkers, we might move in different directions. So if you have biomarkers, your diagnosis will be more standardized, more consistent, and likely more correct if you are able to use those. In the second cases, we didn't have biomarkers, and we do know, I have some folks at my center that for whatever reason, cannot, have an MRI, and I don't have enough funding to send everybody for A beta and tau PETs, and so we may see some cases without biomarkers, in which case you use the data that we have to make the best clinical judgments in a standardized way. I think this gets back to kind of the earlier questions from Diana about, oh my God, do I have to initiate a multi-million-dollar workup for every possible potential cause for a neuropsychiatric symptom? No, you work with the data that you have. I guess, Kostas, do you have thoughts on that?
Yeah, I was sort of thinking more of Diana's question is, so in my regular practice as a psychiatrist, I see a patient who pretty cleanly looks like they fit major depression, for example. I might do a limited workup, common things are thyroid workup, but the workup we do in daily psychiatric practice, depending partly on age, but for young people, we don't usually do much of a workup. For older people, we might. And the point is that the kind of workup that is needed for the psychiatric condition in an 80-year-old is very similar to the workup that you need to make the cognitive diagnosis. Not terribly different.
I agree with that, certainly. We did have a few that came in through the Q&A box as well. Lindsay Clark, did you want to unmute and voice your question for the group?
Sure. My question was about if we should be gathering any additional data, either through screening measures or additional questions while filling out the B9 form to try to map more onto the DSM criteria. I know we ask some questions on there on DSM symptoms, but we may not get information about PTSD or, more specific depressive symptoms, and we might not get information about how much the symptoms are affecting their daily function. So I was just curious about how closely you want us to map onto DSM criteria when kind of filling out these psychiatric history forms, as well as thinking about MBI. Thanks.
Well, I think you use your clinical judgment. You could collect a broad array of psychiatric scales to get you more precise. or you could just ask good questions of your participants in lieu of those measures. I'm comfortable with both. If you are interested in your center getting really good at the nuances of psychiatric differential diagnosis, then yeah, you probably need additional measures and scales. So what we're proposing is a minimum at this point. And as I pointed out earlier, a local site might have a particular measure or scale that they want to use. If you're interested in depression, I would go with the PHQ-9, which is really designed to be exactly the DSM criteria for depression. There are similar measures for anxiety. Boston University is putting together an ad hoc checklist that they plan to use. I've seen a one for major depression, so perhaps you want to have a checklist if you feel that will get you more accurate diagnosis. But my sense is that once you start asking GDS questions and NPIQ questions, and you're careful about the B9 questions, you'll cover the waterfront. You'll miss some, no doubt, and you'll make some mistakes. But I think to be really accurate would be more resource intensive than I think any center can be.
And I'll just chime in on that, yes, the clinical task force looked at this and tried to really find a medium point. We knew we needed to expand our science. We knew we needed to incorporate things like MBI and DSM-5 TR diagnoses into our thinking in a standardized way across centers, but we didn't want to mandate, all right, now your UDS battery is going to be overwhelming and nobody's going to be able to complete it. But again, each of us, as Kostas pointed out, at our individual centers, do more than the core UDS to reinforce our individual interests. So it may be that we end up with a group of centers that really want to dig deep here and maybe put together, a multi-center RO1 or other grant application to collect more expanded data. But overall, we would like a core level of effort and competency at being able to utilize in a standardized way the concepts of NBI and these DSM diagnoses, so that we can separate at times and or incorporate at times the cognitive and psychiatric diagnoses in a more clear manner that is going to help us use the data in a more effective way to answer the vital research questions that we have in the field.
So let me put a little plug, Lindsay, in it. If centers have time and ability to collect one additional scale that would be helpful and interesting, I would encourage centers to do the Mild Behavior Impairment Checklist, MBIC. That covers a lot of symptoms that would be of interest for you. But it's very nice because if someone happens to have MBI, you will quantify the severity. And if they happen not to have an MBI diagnosis, you will still quantify the severity of the MBI symptomatology, which for those of us who are interested in the causes and phenomenology of MBI would be very useful.
So I think that's great, and again, a lot of thought process. I can tell already how much research this is going to stimulate. Hopefully, we do have another question in the Q&A from I may butcher that name, Aransa.
Yes, Arancha.
Okay,
Yes,
very good. Thank you for helping me pronounce that.
That's okay. Thank you for this great presentation. I'm still very early career, but I'm working in a cognitive impairment project in Peru, and I just wonder if this approach is also encouraged for use in other LMICs, or if there are any ongoing efforts towards trying to make data uniform across countries?
Wouldn't that be wonderful, Arancha? I seem to recall there was a famous Spanish tennis player with that name. Do I have that right?
Yes, I
Arantxa
have the same
Sanchez?
last name. Arantxa Sanchez. Yes.
Yeah, right. Wonderful. So I think harmonization is always good. It's not something is in the job or the bailiwick of the ADCs, but certainly happy to help if there are questions about how to go about it.
Yeah, I do think, I'll chime in on that. I think this is a very important question, and I think it just doesn't deal with low and middle income countries, but, may actually have an impact on the different cohorts that we have from different socio-demographic, different racial and ethnic backgrounds. And, and the truth is, we really don't know, we really try to do our best with what we have. Is our social determinants of health form A1A? Is that equally applicable to all peoples of all races and ethnicities, irrespective of their country of origin? We don't know for the social determinants of health. Let alone, but I do believe, Kostas, and you may want to chime in, DSM-5 criteria have been standardized and are used broadly across the globe in low and middle income countries as well as the United States. Am I correct, or am I completely wrong with that?
Well, I think
Yes.
the ICD has been harmonized with DSM. But honestly, I don't know, Greg, who does what these days. Doug, though, lit up, and so sounds like you've got a comment.
One comment I would make about harmonization is that the iStart Cognition peer has made numerous efforts to try to harmonize various cognitive assessments, at least across European countries. And if there are interests in doing the same sorts of thing with entities like MBI, it might be worth trying to work with some or other of the peers to see if they have an interest in at least initiating an effort like that.
Yeah, I'm sure the NPSPA would be very interested. That was the original home of the NBI concept.
And great questions, great discussion today. We're still have a few minutes left and do want to make sure that we capture relevant discussion, make sure that questions are answered. If there are no more, we will end early and give everybody back a few minutes. But this will be a final call for questions, comments. And if there are any folks out there that are real experts in this area, please, if you'd like to chime in on thoughts that you have that may help other centers, we're all in this together. No, and with that, I'd really like to thank, just a big round of virtual applause for Kostas for really helping us today. Big round of applause for NACC for all the training materials that have been put together. The Clinical Core Steering Committee members, Amy, Liana, Doug, and Nina and Cerise, of course, to really make this happen. So thank you all, and I hope everybody has a wonderful weekend.